Excellent. Good evening. Welcome to the annual general meeting and the annual members meeting. I think we're live yet.
Yeah, we're live, Claire.
Welcome to the annual general meeting and the annual members meeting for Sherwood Forest Hospitals, and I'm absolutely delighted for those who are able to join us this evening online. We do hope that in due course we will be returning to in-person meetings for our annual general meeting, but in the current climate I hope that everybody watching understands there are good reasons for doing what we are doing, and perhaps even for many a little more accessible to be able to attend online. So I'm not aware of any apologies that have been sent for our annual meeting this evening, and I know that I've been joined online by my colleagues, executive colleagues and non-executive for Sherwood Forest Hospitals Board. And this is the annual meeting. I therefore have to approve the minutes and matters arising from the last annual members meeting. Those as I've had no questions or queries in relation to those minutes, and therefore with the approval of my colleagues on the board, and I would like to therefore consider those approved. There are no other matters arising from them in relation to that meeting. So I'd therefore like to move to our next item on the agenda, which is the presentation on the annual report. And I'm delighted that we're joined by the Chief Executive for Sherwood Forest Hospitals, Paul Robinson. I'll hand over to Paul.
Thank you, Chair. Good evening. As Claire just said, I'm Paul Robinson. I'm the Chief Executive of Sherwood Forest Hospitals. I'm presenting a summary of the annual report for the year 2021-22, and we're picking out some key moments. I'll start by reflecting on the year just gone. Back in April 2021, I recall a sense of hope that the demands of COVID-19 were over, and hope that my colleagues would gain some respite, and hope that we would start to address the increased numbers of patients waiting for treatment. We now know that 21-22 was equally demanding, with the Omicron variant dominating in the final months of the year. One important distinction to make here is that, unlike in previous waves, we were able to protect and maintain elective surgery and planned activity. However, we do recognise the impact the pandemic has had on patients for waiting longer for treatment than they deserve. We're sorry for this, and we're working really hard to treat people as quickly as possible and prioritising those in most need. On further reflection of the year, there's much to be proud of. I'm proud of my clinical, operational, administrative colleagues. In fact, I'm proud of everyone who contributes across our sites here at Sherwood for keeping services running and keeping patients provided with excellent patient care. I'm proud that we played a significant part in the COVID vaccination programme, delivering over 209,000 vaccinations to date. I'm proud of our teams working so hard to reduce waiting times and continuing to develop services, such as the expansion of surgical procedures at Newark Hospital. I'm proud of the culture we have here at Sherwood Forest Hospitals. Our staff survey results continue to be amongst the best in the country, and we have a zero tolerance on racism and abuse. Lastly, I'm proud of all my colleagues, and I hope that they are proud of themselves for what they've achieved for patients and for Sherwood Forest. As I look at the key moments and metrics of the year, it's worth noting the view of our regulators and our national reputation, of which we're so proud. Our Care Quality Commission ratings remain unchanged. Overall, we're rated good, with Kingsmill Hospital rated outstanding. And just as 2021 began, we were awarded Trust of the Year by the Health Service Journal. The key moments of the year are included in our annual report summary and include celebrating the 100,000th COVID vaccination in May, unveiling our gamma scanner in June, and when we also rolled out our carers passport and opened our same-day emergency care unit. The year saw changes in our senior leadership. In September, we said thank you and farewell to our Chief Executive, Richard Mitchell, and I stepped up as interim. In October, Claire was appointed substantively to the role of chair, and over the rest of the year, we welcomed 3 new non-executive directors to the board, Steve Banks, Ali Rashid, and Andrew Rose Britton, and we thanked Tim Reddish and Neil Gossage for their contributions to the board. My very first act as interim chief executive was to take part in the opening of our new mobile diagnostic unit at Kings Mill. Surgical procedures were expanded at Newark in November, and the Trust declared climate emergency and committed to actions within our Green Plan during December. February saw the launch of our anti-racism strategy during Race Equality Week, and in March I was delighted to be appointed substantively into the role of Chief Executive. This was the first of 5 executive appointments, and over the next few months we welcomed Phil Bolton as Chief Nurse, Rachel Eddy as Chief Operating Officer, and David Ainsworth as our first Director of Strategy and Partnerships. We also congratulated Rob Simcox and Rich Mills as they stepped up into the roles of Director of People and Chief Financial Officer respectively. In March, we rolled out staff-worn cameras as part of our commitment to reducing violence and aggression. And also in March, we welcomed the publication of the National Staff Survey results I mentioned earlier, and more on those to come later. Lastly, March also marked the International Day for Elimination of Racial Discrimination. So, a busy year and much to celebrate. I mentioned changes to the board and the executive team, and here's the current lineup. A new look for the leadership team as we head into 22-23. There were also changes to the Council of Governors following elections that were held in April, and we welcomed 7 new governors, with 3 governors being successful in re-election. If we take a look at some of the statistics which describe the year, we can see that it's been an incredibly busy one in the emergency department, with attendances increased to over 111,000, and in fact, since then, during this year, we've seen them increase even further. And over 81% of people were seen within 4 hours. Rich Mills will go through the details of our finances, but in summary, we spent £437 million providing care, of which £294 million were paid to staff. 76.3% of our staff had the flu jab, above the national average, and our sickness rate was below the national average. And we're proud to have 20 wellbeing champions now supporting our colleagues with their physical and mental well-being. Lastly, I mentioned earlier our staff survey results. 66% of our colleagues completed the survey, and that's one of the highest responses across the whole of the NHS. And of those responding, 81.7% of our colleagues said they would recommend Sherwood Forest hospitals as a place to receive treatment. That's the top score for the whole of the Midlands. And of those colleagues who responded, 74.9% said they would recommend Sherwood Forest hospitals as a place to work. And that's the second top score in the whole of the country. So there it is, a summary of the year. The full annual report and accounts can be found on our website, and I'm hoping that you can find a link to that in our chat publication as we go through this evening. Thank you for listening. Thank you for the support that you've given to the Trust over the year. Thank you for the support you've given to me personally and also to the executive team and the board. Claire, back to you.
Thank you, Paul. And I think that is a great set of highlights of our year. Despite all the challenges that we've had, I think our staff have delivered an amazing job for our patients and for our community. And we're very grateful to them and to all who've supported us in allowing us to be able to do that. I'm delighted now to welcome Richard Mills, who's our Chief Finance Officer, and as you will have seen from the reports that our Chief Executive just gave, that Richard joined us as the Chief Financial Officer this year and stepped up from his position as the Deputy. So welcome to this, Richard, and I'd like to ask you to present the annual accounts, please.
Thank you, Claire. Good evening, everybody. Thank you for joining the AGM this year. So I've got a few slides just to provide an overview of the 21-22 annual accounts. I'll then hand over to Richard Bolton, who represents our external auditors, KPMG, to talk you through our external auditors' annual report. So in terms of the key matters, as usual, the annual accounts have been prepared in line with the Department of Health and Social Care's Group Accounting Manual, known as the GAM, on a going concern basis. And effectively that means that it's the basis that the organisation will continue to operate over the coming year. The accounts are made up of 4 main statements, which I'll come back to in a moment. But in the year, there have been no changes to existing accounting policies to note. These accounts were presented to the Trust's Audit and Assurance Committee on the 17th of June, prior to sign off by the Board of Directors and KPMG with an unqualified or clean audit opinion. So the 4 main statements that I mentioned, the first of those is the Statement of Comprehensive Income, or SOCI, which is also sometimes referred to as the Income and Expenditure Statement or the Profit and Loss. It's worth noting 21-22 was another challenging year in the world of NHS finance due to the levels of uncertainty faced. The financial year was broken down into 2 halves, with allocations and expenditure plans provided for 2 6-month periods. Much of our funding in the year remained on a fixed basis, as it had done in the previous year, with some variable income earnable through the recovery of elective activity. Our ability to earn as much funding as we'd liked was hampered by the operational challenges that we faced, in particular through the winter period as we managed the Omicron COVID surge. Overall, for 21-22, our account showed a retained deficit of 1.3 million. However, our regulator, NHS England, they assess our performance on an adjusted basis, so that excludes any impairment adjustments or the impact of donations or related depreciation. So from an NHSE point of view, our accounts for the year showed a deficit of 13.2 million. This was aligned to a forecast outturn that we reported at the end of Q3 and agreed with integrated care system partners and NHS England. The second main statement is the Statement of Financial Position, or more commonly known as the balance sheet. So that shows the value of assets such as our property, plant, equipment and our cash holdings, and also our liabilities, for example, borrowings and payables. So that shows the position as at the 31st of March 2021. The final 2 statements are the Statement of Changes in Equity, which records how the assets of the Trust are financed by the Treasury, and the Statement of Cash Flow, which records movements to the cash holding of the Trust from the start of the financial year to the end of the year. In terms of the findings, I'm pleased to confirm that we received an unqualified opinion. So that means that the assessment of the accounts give a true and fair view of the financial performance and position of the Trust. There were no unadjusted differences recommended or made to the draft accounts, and no material weaknesses identified with regard to value for money. A medium-term risk in relation to financial sustainability was noted. That's linked to the underlying deficit and large efficiency target faced by us, together with challenges in relation to funding at a national level for the NHS. These are issues that are affecting many NHS organisations. Finally, just before I pass on to Richard, I'd just like to recognise the incredible efforts of our operational and clinical colleagues throughout the year, and also pass on my thanks to the finance team and everyone involved in producing these accounts. I'll now pass on to Richard to present the External Auditor's Annual Report.
Thank you. Thanks, Richard. So I'm Richard Bolton. I'm the External Auditor to the Trust, and I am different to the other people who were presenting in that I work independently. I work for KPMG, so we are an independent company that sign off the accounts and the annual report and issue an audit opinion separately to the work of the Trust. So our role is to be independent, and if we disagreed with the things that were in the annual report and accounts, our report would say as such. If you can move on to the next slide, please. The slide that I'm going to take you through is a summary of our annual auditor's report. The full document will be is on the Trust website, so you'll be able to find a copy of that. There's a little bit more detail in there than is I'm presenting to you tonight, but I'm conscious it's quite small typing on the screen, but you'll be able to download a full copy and read it at your leisure. But I'll take you through the main headline messages. In my role, I'm required to give various different conclusions and opinions in relation to an NHS entity. The first one is the one that's pretty standard for all entities as an external auditor, in that I'm required to give an opinion on the financial statements, whether they represent a true and fair view of the financial performance of the trust to the year ended at March and the financial position at that date. I gave an unqualified opinion, which is a slightly odd word, but it's the one that you want. It means that I'm happy with the content of the report and that a true and fair view is represented, and so that's a positive outcome for yourselves as a trust, and there was no qualification or any issue that I wish to flag in detail there. I also, within that report, noted that I was content with the annual report on a wider basis, that there were no inconsistencies within that, either in terms of the guidance or my wider knowledge of the trust. And then before I go into the next slide, I've got various other powers that I'm allowed to do. Either I can report things to the Secretary of State if I think something is going to happen that is not consistent with the legal basis, or something's happening inappropriately. I have powers to report that, and I'm pleased to say that I didn't report anything this year. There was no such thing brought to my attention that required such action. The next slide explains the core kind of financial risks that were within the financial statements. Yeah, that's thank you. There were 4 risks that we looked into that were noted as significant, that we did a bit more detail on. The first one and second one are standard risks within NHS bodies that we think there's a significant risk of the income of the trust being misstated, in your case being overstated, to make the financial position look better. And the same way with expenditure, that expenditure is being incorrectly stated in order to hit the target that you were set. We did lots of work to check that out, and are content that there's no issues within the final version of the accounts, and indeed there are no significant adjustments to reflect that. The third one down is a risk that's about a risk of error, that your financial statement, the valuation in regards to the way in which your property, plant and equipment are held, that is misstated. We did lots of work looking at the information that's passed back and forth from the valuer, the professional person that values your hospital, and we're content that there were no errors within that required stating. And the final one is an auditing standards requirement around management override of controls. That's something that we're required to assume is a risk at every entity. So just to reassure you, I don't have concerns that management are being inappropriate with controls. It's something I'm required by auditing standards to assume. So they're the four risks that I worked on. That was the focus of our audit work, and there were no large concerns that we're required to report or weaknesses in regards to that. My final slide is in regards to the value for money work. This is it was brought in last year, so last year was the first year of it. It's something slightly different to the long-standing work in the NHS, and that we're required to comment on whether there are significant weaknesses in the trust arrangements, rather than saying overall whether things are okay. So the table on the right hand side gives you the summary there. As you can see, it's there's lots of green bits within there. So overall, with the 3 areas that we're required to assess, the end output was that we were content that there were no significant weaknesses. From our initial risk assessment work, we considered that there was one area where there's a risk of a significant weakness, and that was in regards to financial sustainability. I'd just like to make that clear that was a risk that we raised at quite a lot of our NHS bodies, due to the wider issues in the NHS, and at the time of our risk assessment, the lack of certainty about the medium-term way in which the NHS was set up in terms of what government had announced exactly at that stage. However, we've done the work that we're required to do, and we're content that at the year end, and indeed in the report, there's no significant weaknesses in regards to the trust. So that concludes all the work that we did, and overall those conclusions and messages are all the positive ones that you'd hope for your trust. And so happy to take any questions along with the when the Q&A session is. I think I'm handing back to Claire, who's yeah, I'll hand back to Claire now if that's okay.
Thank you very much, and apologies for a slight change in background. I'm having some technical issues, but can I thank both Rich and Richard for their presentations. We have an opportunity now for a panel discussion and for questions. We have received one question so far, which we have available to us, and perhaps I can encourage those who are watching, should they wish to ask some questions, they can submit them through the Q&A box that they will see on their screens, and we will certainly do what we can to try to answer those. So initially, our first question, which is available to us, which comes from a GP's practice, Carter Singh, and I'd like to ask David. David, you have our medical director. You have the question available to you.
Thank you, Chair. I will just find the question. Actually, I was hoping that here we are.
We have the question up, and the question is placed.
So the questions there shown on the slide. If we just put that back up again, if we can just show that slide again. And I think it's a very good question. I think the fact that both Sherwood Forest hospitals and Nottingham University hospitals have this week declared internal critical incidents certainly reflects the pressure that we as hospitals are under, and as the Chief Executive was describing, you certainly have seen the significant increase in the attends from our emergency pathway, and you will all recognise, I am sure, the impact that COVID has had on our non-emergency pathway, on our elective care. And in reality, I would say that, of course, it's not just the acute providers, the hospitals that are under pressure. It's all components of the healthcare system that are feeling that pressure. And again, there's a lot of national reporting around the ambulances, the ambulance turnarounds, the waits, the social care, the impact that that's having on our ability to provide care in a different environment, and of course our colleagues in primary care, which is what Dr. Carter Singh is referring to. And I have absolutely no doubt that we must all work together to address all of these aspects, and that's because they affect us all. What I would say is that the closer arrangements, the new arrangements with our integrated care system, our integrated care board, our provider collaborative, and our place-based partnership does give us probably unique opportunity to improve things than historically where those have been. And from my point of view as the medical director, I fully recognise that this sort of historic symptoms of the past, of a tendency to pass everything back to our general practice colleagues, and that's very irritating for our general practice colleagues. It's also irritating for our patients. But to do this, we've also got to work differently. I don't think that we can continue to provide healthcare in the same sort of way, otherwise we'll end up with the same sort of results. And so I'm sure Dr. Singh will agree with me that we've got to have not just for hospitals, not just the acute providers, but all of us in healthcare, we've got to have a mindset change of how we consider the way we provide services. And I think key to that is actually thinking about pathways as opposed to specialties, where historically we've considered things in terms of the diagnosis and the specialty, but it's more about the whole pathway, the whole journey. And if I gave an example of that, I might sort of consider something akin to the lines of what we might call perioperative care or the surgical pathway. So in the past, we've considered the surgical event as the be all and end all, and I think we need to reframe that language and think of the surgical event as more as a sort of punctuation point. But it's all about the preparation of the patient and the recovery of that patient that is going to be key to all of this. So it's thinking about things in a different way. And that reframing the language is really important. So what I might say is that the key bit for me is to change that mindset from thinking about waiting lists to actually thinking about preparation lists and how we can help patients to get prepared, fitter, better prepared to withstand surgery. And that will involve us changing how we do things, investing in things such as prehabilitation and recovery. And it's not just us in secondary care who have to change how we work. GPs also are going to have to change the ways that they work, and I'm sure Dr. Singh doesn't need me to describe what that might look like. But I would say to Dr. Singh that I've had extensive discussions with the President of the Royal College of General Practice on the role perhaps of changing perioperative care pathway. So things are happening, and I hope we can work together and make those better. I think the other final bit I might just say about this is that whilst the partnerships are really important across the primary, secondary care, social care, I prefer to lose those terms and just call it care, but to call all the healthcare providers. I think perhaps the point that we mustn't lose sight about is just encouraging our patients, our community to perhaps a seismic change, a paradigm shift in how they consider healthcare provision, and just helping them to recognise the actual role that they have in their own health and the impact that they can have in their own health. And this really is a partnership between us as healthcare providers, but also the patient, and taking some ownership for that. And as part of that, as healthcare providers, I think we've got to really invest very significantly in the prevention agenda, those key aspects in terms of reducing smoking, reducing alcohol consumption, reducing obesity across all of our patients. And it's these aspects that we have to work together with our general practice colleagues to get much better at, because that's the only way that we'll be able to get a fitter, better population, which will be the future. And our GPs are obviously key in all of this, and I would look forward to working with Dr. Singh in truly making every patient contact count, be that in secondary care or primary care. So I'll stop there, Chair, and hand back to you.
Thank you very much, Dave, and very grateful to Dr. Singh for his question and his participation and interest in our annual meeting. As I said, we are encouraging members of the public and, of course, our members to ask questions. We have received another question, which comes from Mick Holmes. Is there any specific action being taken to address violence and abuse against staff, especially in A&E? Are victims encouraged to report such incidents to the police? And perhaps I can ask my colleague, Rob Simcox, who is our Director of Culture and People, to join us to answer that question, please.
Thank you, Claire. Thank you, Chair. I think what I'd be more than comfortable to do is take 3 points in regards to that point of clarification, and I'll probably bring David Ainsworth in as I move through my response. I think we've got to recognise, and Paul touched this from the onset, about the support that we're giving our workforce in regards to difficult circumstances they may face when providing services, particularly in our emergency department, and we've equipped colleagues with body cams that came in earlier in the year to give individuals confidence that when they're put in difficult situations, that there's evidence there that can be used and formulate any possible prosecution that may come from circumstances which can be of a very challenging nature. So that was the first point to just make reference. I think the second point is to talk around the wraparound wellbeing support that is available to our workforce, to our people, should I say, and how reactive and responsive we've been to ensure that that's available to individuals during such circumstances. I think it's fair to say these circumstances do take place, and I take pride in the support that is on offer to colleagues to access in times of difficulty. And I think the third bit, which I'll bring David in, is some of the collaboration that we're starting to do with partners, particularly at Place, in regards to recognising this is a zero tolerance approach that we take in regards to behaviours that we don't feel is acceptable.
Thank you, Rob. David, would you like to add to that?
Yes, thanks very much, Claire. Thank you, Rob. Good evening, everybody who's watching this. Thanks very much for joining us. David Ainsworth, Director of Strategy and Partnerships. And quite rightly, it's an important topic for us to talk about. So I'm really grateful to the person sending the question in. There is no circumstances apart from the obvious medical ones where somebody perhaps has an underlying medical problem like dementia, for example, but parking that to one side, there are no other circumstances where it is acceptable for our staff to face violence and aggression. And sadly, having been in the NHS for 30 years, it is something that's on the increase. And as Rob said, we do have an open culture and support our staff to report all incidents and ensure they get the appropriate level of support thereafter. And in addition to that, we know this isn't sadly unique to the NHS and certainly not unique to our hospital. So the work that we're doing with partners now, which includes the police and crime commissioner, our colleagues and partners in local district councils, whose quite frankly public facing staff also experience episodes of violence and aggression. We are coming together to look for new ways in which we can say to people this isn't acceptable and that action will follow. So I think that's an early start in the conversation with our partners across the system. But I want to be really clear, because this meeting's in public, that we will prosecute, we won't accept violence and aggression against our staff. There simply is no place, and we've already heard of the increasing pressure our staff face. So I say to everybody, please be kind, please be patient, and if you start from a point of asking for help, our staff will understand your frustrations and they'll do everything they can to support you in resolving those. Thank you, Claire.
Thank you very much, David. I think we probably have hopefully answered that sufficiently. I do have another question that's been asked from Ian Holden. How far on are we with the development of the virtual ward concept as a response to the pressure we are under? So perhaps I can start with our chief nurse, Phil Bolton.
Thank you, Chair. Good evening, everybody. Thanks for the question, Ian. I think it's fair to say it's a relatively new concept, but a very important concept, the virtual ward. Opportunity to care for people outside of the hospital environment within safe parameters and with support from our medical staff and MDT colleagues. I think in terms of the impact that we're going to see this year, this winter, and the impact on our bed base and perhaps reduction of inpatient bed days, I think if we're really honest, it is in its infancy. I don't think we can expect to see huge amounts of impact in terms of beds saved, but I think the opportunity to provide a sort of patient focused pathway that allows people to not be in hospital, whether it's for one or two patients, I think that's really important and the right thing to do for our patients. So as I say, it's very early days. We've only had a number of people go through it effectively, but I think it's something that will grow, and it's something that we've got to continue to focus on so that it pays more dividends over the coming months and years. And I think a few years down the line, we'll be talking about this in a really different way. But it's not going to have a huge impact this year, but it'll have a huge impact on the patients that go through that, whether that's a few patients or bigger numbers. Dr. Selwyn, I don't know if you want to add anything to this.
No, I think you've to be honest with you, you've covered most of it. Yeah, I guess the only thing I would say is that as Ian is aware, what we need to do is build this slowly and make sure that it's safe and we've got it right, and that's the key bit, because as you say, then it will be really something important and powerful for us.
Excellent. Thank you very much, Phil. Thank you very much, Dave. Those are all the questions that we've received. Obviously, if members of the public have questions in future in these, we encourage you to send them in to us, either in advance, which is helpful, or indeed on our platforms when you're attending the annual meeting, but also our board meetings, which take place in public. They are not public meetings, but they do take place with an opportunity for members of the public to view them online at the moment and to be able to ask appropriate and relevant questions. So I would encourage members of the public to do so. Well, I'm now going to go on to our next item, which is to discuss the constitutional change that is being proposed. And that constitutional change for obviously our constitution at Sherwood Forest Hospitals is going to be led by our lead governor. Our lead governor, Sue Holmes, will, along with Shirley Higginbotham, who is our Director of Corporate Affairs, and they will take us through the proposed changes to the constitution.
Thank you, Claire. Good evening, everyone. I'm Shirley Higginbotham, the Director of Corporate Affairs. It's a statutory duty for the annual members meeting to approve any changes that have been made to our constitution during the year. And it's also a statutory duty that the Council of Governors or the lead governor present those to the annual members meeting. However, I just wanted to, as part of my introduction, say that these have already been approved by the Council of Governors and the Board of Directors. We haven't received any questions prior to this presentation. If you do have any questions or queries, if you could put them in the live Q&A, but if you could state your name and the membership constituency you're representing, please. Just before I hand over to Sue, I just want to point out there is a typo on the slide. We have maintained 14 public governors, but that's 4 for Newark and Sherwood and 10 for the second constituency. So although we've maintained it, there was a bit of a typo with the 2 for Newark. It's actually 4. So now if I can just hand over to Sue, who will take you through the remainder of the proposed changes. Thank you.
Thank you, Shirley. Good evening, everybody. I'm Sue Holmes. I'm lead governor, but I'm a public governor for Ashfield. We aren't proposing to reduce the number of governors, but we have found it difficult to fill all of the places that we have, particularly the rest of the East Midlands. We have an allocation of 2 governors for that, and nobody was willing to stand in the elections that we had in the first part of the year. So we are proposing to keep the 4 governors for Newark and Sherwood. That's not changed. But we're going to amalgamate Ashfield, Mansfield and the rest of the East Midlands to a total of 10 governors there, which hopefully will let us fill the 2 vacancies we have. We are changing the staff constituencies, not the number of staff governors, but we aren't making them site specific. We used to have 2 for Kingsmill and Mansfield Community Hospital, 1 for Newark. We want to just have 3 staff governors over all 3 sites. So they're the changes that we are asking you to approve, please.
Thank you, Sue. So can I encourage members of the trust to indicate in the Q&A panel that they are happy to approve, or if there is any specific issue that they have or a question. We will, given that this has gone through the Council of Governors and it's also been approved by the board, if we don't have any objections to this, we will take this as approved. Okay, thank you very much, and glad to approve that. Thank you very much, Sue, for the presentation, and thank you to all of our governors for the work that they do on your behalf. They give their time, they're not remunerated for that. They come into the hospital to support the work that we're doing, to help ensure that the board, the non-executive directors on the board, are also held to account and are undertaking the roles appropriately and performing appropriately in those jobs. And we're really grateful to all of our governors for their support and for their activity, and we hope that in the work that they do, that they are able to extend out into the community and to reach as many members of the public as possible, to understand how we can continue to improve our services and to improve what we offer at Sherwood Forest Hospitals. If you are interested, you're watching this tonight, or indeed at some other point, and you're interested in perhaps becoming a governor or just finding out more about being a governor, then please get in touch. We would love to have more members of the public representing and taking part in the work that we do at Sherwood Forest Hospitals. So I don't have any further questions having been asked. I'm delighted that we have a number of people that I can see are viewing and watching this tonight. I'd like to thank all of the board for their participation and for taking part and being available for this evening, but also specifically to thank our staff for the work that they do, and they are continuing to serve our community and our patients, and we are very grateful during what is certainly been a very difficult year, and undoubtedly will continue to be difficult times in the health service and for our community. So I'd like to thank all of you. I'm delighted to reach the end of our annual general meeting, to thank everybody for their participation and to close the meeting, and look forward to seeing you all again at the annual meeting next year, but hopefully many more of you will want to participate in our activities and our events. So please keep in touch, and please watch our website and our communications to see all of our activities. Thank you once again, and I'll officially close the meeting.